Can everybody see chapter 28? You know, as long as I've been doing this, it just doesn't get any easier. I don't know what it is. I think I'm just, okay. Um, I'm still converting my brain over to Canvas. I've been doing Blackboard for so long. We are going to be talking about chemotherapeutics, and this is going to overlap a little bit also on what we are talking about with um, in perio as well. Chemotherapeutics. You're going to have an entire um, chapter on that. So you have your patient in the chair. You have you've assessed. You've done your perio assessment. You have done your hard tissue assessment. You know what type of inflammation they have. Okay, and we know with the oral systemic link that the inflammation in their mouth does not just stay in their mouth. It's been linked to everything throughout the body, including Alzheimer's, cardiovascular disease. We know that diabetes is bidirectional. Also, you know, the blood sugar control and the amount of inflammation. So oral inflammation is really linked to several conditions, and that's what we need to help educate our patients with. And I think this is what commercials are doing a nice job of as well, is linking diabetes with heart disease, for example, not necessarily oral disease, but they're educating the public. So an increased inflammation has been associated with diabetes that can make the patient more susceptible to periodontal disease. Bidirectional. Oral pathogens can travel to the lungs. This is especially true with hospital patients, okay, and those patients that have been intubated. So chemotherapeutics can be administered by you, the clinician, or the dentist, or the patient to help alter the type of bacteria that's in the patient's mouth, as well as I just lost my train of thought. So we're going on. Okay, so toothpaste. What's one of the simplest things that the patient can use as a chemotherapeutic agent is toothpaste. And what is the primary role of toothpaste? Why are we using toothpaste? It tastes good. It's a surfactant. It makes the teeth feel slick, okay, because it's got glycerin and all sorts of other things in there. Does it, are the teeth slick? Not necessarily, but it puts the glycerin film over everything. So the toothpaste is just like putting soap on. You still need the physical action of the brush. That's what's disrupting the bacteria. The toothpaste is also a way to get some of these chemotherapeutic agents to the tooth. And one of the primary ones is fluoride. Primary chemotherapeutic agent, okay, is fluoride. And depending on the type of fluoride, is it just for cavity reduction? Is it for desensitization? Is it for what other things is that fluoride doing? So dentifrices will help remove biofilm, stain, and other soft deposits because it has some abrasive particles in it. Toothpaste by itself is not going to do that. Dentifrices toothpaste also is a way to apply therapeutic agents like fluoride, like potassium nitrate. 5% potassium nitrate is a desensitizing agent for exposed root surfaces. They have been experimenting a lot with trying to add chlorhexidine into toothpaste, but it's not stable. So that's never really come out. And you can have a superficial cosmetic effect. That superficial cosmetic effect is removing stain. But a lot of these chemotherapeutic agents that we're using is for prevention. We want to prevent dental caries by disrupting that bacteria with the toothbrush and applying fluoride through the toothpaste. Remineralization of early non-cavitated caries through fluoride, through something like amorphous calcium phosphate paste. To reduce the biofilm formation, you want to disrupt all that biofilm, remove it if you can, then all that bacteria has to recolonize and form again. So we know it takes about 24 hours for the bacteria to start producing those harmful effects. So if the patient is doing a thorough job once every 24 hours and they're not at a caries risk and their gum tissues are healthy, I mean, yeah, we'd like you to be brushing and flossing more frequently, but hey, you're getting away with it right now. Reduction of gingivitis and inflammation. Now, some of that could be from chemotherapeutic agents like chlorhexidine, like the stannous fluoride. Some of it is simply from removal of the biofilm. So the question is, don't they have antimicrobial toothpaste for patients going through chemotherapy? Yes, they do. There are a lot of specialty pastes out there as well. Some prescription, some not. Reduction of dentin hypersensitivity. That's the potassium nitrate. We're finding potassium nitrate is being placed in a lot of toothpaste, even if it's not being billed for desensitizing. The Pronamel, it has not only potassium nitrate in it, but it has stannous fluoride in it. Stannous fluoride is a great fluoride for its bactericidal. It desensitizes exposed root surfaces for dental hypersensitivity, and it's a cavity fighter. So stannous fluoride is one of the best things that the patient can put in their mouth. Tastes awful, so they've been working on formulations for that, but that is what that Pronamel is. It's made by the Sensodyne people, the GlaxoSmithKline people. They have Sensodyne toothpaste, which has the potassium nitrate in it and fluoride, but it's not the stannous fluoride. Their Pronamel has the stannous fluoride in it. The reduction of supragingival calculus formation. The pyrophosphates. That is the tartar controlled formula toothpaste. Pyrophosphates. Some people have natural pyrophosphates in their saliva and they don't produce a lot of calculus, just naturally. Other people don't, and you swear that that calculus is forming while you're waiting for a polish check or a scale check. You swear it wasn't there before you signed up for a check. Cosmetic effects, removal of extrinsic stain. Those are where the abrasives come in. And the reduction of malodor or halitosis. That usually covers things up. Okay, it's got the minty flavor to it, but they're also having other ingredients in there like chlorine dioxide and other chemicals in there that can neutralize that sulfur compound producing bacteria. And that causes bad breath, and that's halitosis. Reduction of malodor either chemically or physically with the removal of the biofilm, the disruption of the biofilm. You do need to know some of the basic components of the toothpaste, of Dentifrices. So review that. You've got your detergents, your cleaning and polishing agents, and then your binders or thickeners. If toothpaste didn't have all of this stuff in it, it would dry out very fast and it wouldn't stay a cream or a gel. So detergents are the foaming agents and surfactants. Now, one of the primary foaming agents is sodium lauryl sulfite, SLF, and that is associated with canker sores. Patients who have a lot of aphthous or aphthous ulcers chronically, you want to find out what toothpaste they're using and advise them to try and find something that doesn't have that sodium lauryl sulfite in it, that SLS in it. All it does is foam. Okay, and it's put in your body washes, it's put in your the hand soap that you use, the liquid hand soap, it's put in your dish detergents, because we think of bubbles and suds as cleaning, and it's not necessarily so. Plus, the SLS has ingredients that they take from the rainforest, and so it's not one of those eco-friendly agents as well. So if you're on the green side, you want to stay away from SLS anyway. Surfactants is something that just helps things slide off. Okay, it's putting something on your tooth to help the debris slide off. Cleaning and polishing agents are the abrasives, and the whitening toothpaste tend to be a little more abrasive than the non-whitening toothpaste. There is something called that Mohs hardness, which we'll get into, and there's a scale of abrasivity that these toothpastes have. Crest used to be one of the more abrasive toothpaste, but it was still on the mild side. So depending on if your patient has a lot of root surfaces that are exposed, you don't want them using something abrasive. Then you've got your binders or your thickeners. So these will be reviewed also on your board review, because these are board questions. What's in it? You have humectants. Those are stabilizers to keep things moist, to keep it a cream and not a dried out paste. You have preservatives, so it'll last long. And then you have flavoring agents, and those flavoring agents are usually sweeteners. Mint seems to be associated in this country with a fresh feel. Mint and cinnamon are two of the most popular breath fresheners, but patients can be very sensitive to cinnamon. That's a highly allergic ingredient. So you want to, if patients are complaining about tissue sloughing and other things after they brush their teeth, you want to be looking at what they're using. Flavoring agents are usually the non-sugared kind or an alternate sugar, like the xylitol, malitol, other things. You're not swallowing them, so it's okay. But some patients can be very sensitive to them as well, their oral tissues. So what are the active components of dentifrices? The first active component was fluoride, and Crest Procter & Gamble was the first toothpaste to incorporate fluoride in it, and it was a stannous fluoride, which was a great fluoride, but it has some side effects to it. But when Crest came out, they were saying that they have prevented more cavities than all the other toothpastes combined. And it's true, because Crest was the first toothpaste to come out with it, and they were using fluoride for a number of years before all the other toothpaste companies got on board. So they have prevented more cavities than all the other toothpaste combined. But what else can they do? Fluoride is anti-caries. Some fluorides, like the stannous fluoride, are anti-gingivitis. So those the toothpaste that you see that like the gum care and the periodontics from GlaxoSmithKline that says it helps reduce inflammation and reverse inflammation, that has the stannous fluoride in it. All right, stannous fluoride is also anti-biofilm. It kills the bacteria, bactericidal. Anti-calculus is the pyrophosphate. Now, this anti-calculus does only work on enamel and above the gum line area. So if you have somebody that's a heavy calculus producer and they have recession and root surfaces are what it's accumulating that calculus, those anti-calculus toothpaste or tartar control toothpaste aren't really going to help that person. Anti-oral malodor, those are the flavoring agents, but you do have other ingredients, like I said, chlorine dioxide that can help with the halitosis. And anti-sensitivity is usually the 5% potassium nitrate as well as the stannous fluoride. You have toothpaste with both of them combined now. So the patient's going to be asking you, what toothpaste should I use? What are you going to tell them? You want them to find something that they like to use. Some of this toothpaste tastes awful. I do not like Sensodyne toothpaste. I did not like one of the Pro Health toothpaste that Oral-B came out with. And those are two different companies, but they just made my tongue feel bleh. So I didn't like them. So patients will have a preference. And that's one reason why these companies give you and give the offices toothpaste to have the patient try them. If they like them, they will go out and buy them. So we have a lot of Pronamel and Sensodyne in our office or in the clinic because GlaxoSmithKline gifts it to the school so you can give it out to the patients. Next year, you'll be working with Johnson & Johnson, and they will be giving you also their array of mouthwashes and dental floss so you can customize what you are recommending for your patients. So who's going to be using it? Considerations for pediatric patients. Do you even want them using something with fluoride in it? Some of the new toothpaste for really young patients don't have fluoride in it because a toddler is not going to know how to spit. They are going to chew on that brush and swallow. So you want to have something with as little or no fluoride in it for them, and you want to monitor them. And then your patient-specific recommendations. So you want to be asking your patient. We've got a lot of mouth rinses out there, and Johnson & Johnson has made a great publicity campaign on brush, floss, and swish and rinse. Brushing and flossing doesn't get it all. Rinsing, okay, doing all three gets it all, right? So mouth rinsing has become popular. Does everybody need it? No. And there's lots and lots of different kinds out there. Most of them contain alcohol. Some of them contain things to reduce inflammation. Some of them contain fluoride. So you want to customize what is the patient looking for. Some of them say that they have whitening ingredients, and what those whitening ingredients are, they might have a little bit of bubbling action like peroxide, but they also have more surfactants to not let the stain stick to the teeth. So it's a supplemental mechanical aid. It does not replace brushing or flossing or the water pick. It needs, that bacteria needs mechanical disruption. So these mouth rinses can be preventive, cosmetic, or therapeutic. There are chemotherapeutic rinses that can reduce inflammation. Your chlorhexidine, for example, is a prescription. You also have stannous fluoride mouth rinses, which are prescription, bactericidal, as well as the other benefits of the fluoride that are in there. There are therapeutic rinses that can have healing properties. That's your usually your oxygenating, chlorine dioxide type of properties just to help soothe and wound healing. Therapeutic rinses that have healing properties could also be the chlorhexidine. Kills bacteria. And mouth rinses deliver an agent less than 2 millimeters into the sulcus or the pocket. So if you've got 3 millimeters or above, swishing is not going to do anything to get that mouth rinse subgingivally. But we know what happens on top of the gum has a great effect on what's underneath the gum. So the more the patient can work with what's going on top of the gum, the better. But if they've got pocketing or attachment loss, maybe they need a water jet or a water pick device to introduce that mouth rinse or that chemical agent farther underneath the gum tissue. Maybe they need to be dipping their brush and brushing with a mouth rinse or putting it on a proxy brush to introduce that chemical in between the teeth. So we've got our chemotherapeutic agents. Astringent is highlighted here. That shrinks the tissues. And what is the biggest astringent that is used in mouthwashes? Alcohol. Alcohol is a great vehicle for stabilizing the mouthwash ingredients, as well as giving you that tingly feeling. Others use different thymols and other things, but astringent shrinks tissues. It can also dry the tissues. So we've got remineralization as a chemotherapeutic agent. That's usually fluoride. Antimicrobial, bactericidal, or bacteriostatic. Is it keeping the bacteria where it is, or is it actually killing bacteria? The difference between Listerine is bacteriostatic temporarily versus bactericidal is the chlorhexidine. Astringent helps shrink tissues. It can help alleviate pain. What is one of the solutions that you tell patients if they have something going on in their mouth to help soothe the tissues? Warm salt water. Okay, it depends on the pH and everything else, but some of them could, like glyoxide, could have bubbling effervescence, as well as a little bit of pain alleviating ingredients in them. Buffering to reduce oral acidity, deodorizing, as well as oxygenating, which helps cleanse. So those are the functions. The purposes of mouth rinses, we have our patient do a pre-procedural mouth rinse. There's been a lot of debate since COVID as far as what is the best mouth rinse. So everybody was getting on the bandwagon with you needed to have an oxygenating mouth rinse to neutralize the COVID, but the COVID was coming from the patient's lungs. So unless they were really inhaling the oxygenating product, if they were breathing through their mouth, it wasn't really doing any good. But it does reduce overall bacteria that's in the mouth. Having said that, that reduces the overall aerosols, the bacteria that's in the aerosols that we routinely produce. So it's more beneficial for us because we're the ones sitting in that bacterial soup, right? Patient after patient after patient. So pre-procedural professional treatment, that can help reduce the bacteria that's in their mouth prior to a procedure. It can help sanitize the mouth, especially if you're doing an injection or something else or an invasive procedure. It will not take the place of having the patient, though, brush and floss or take care of their teeth before they sit down in the chair. That's still the most beneficial thing that they can do. Is have the patient go to the bathroom, here's the disposable toothbrush, and brush your teeth to sanitize your mouth before you come back. And then for mouth rinses, it's for self-care as well. There is fluoride mouth rinses you can get over the counter or prescription, as well as chlorhexidine, which is just prescription. And CHX is the abbreviation for chlorhexidine. It has a different abbreviation in the hospitals. I don't know why. Triclosan has been in Colgate Total for years, but it is now banned as of a couple years ago in the United States. They have, Colgate Total has changed the triclosan to a stannous fluoride. Triclosan was getting in the waterways and really disrupting our water ecosystem tremendously. Then there are the essential oils, the phenolic related essential oils. And when we say essential oils, is there a brand that comes to mind? The brand is Listerine. They use essential oils. Quaternary ammonium compounds, oxygenating agents do just that. They bubble, as well as oxidizing agents, which will oxidize, or that bubbling action brings air to the necrotic tissue and can help heal. So review what the active ingredients are. Now, the active ingredients are what they are claiming the toothpaste does. Prevents cavities. What would the active ingredient be? It would be fluoride. Prevents, okay, reverses inflammation or gum disease or whatever the claim is. It's going to be whatever agent they're making the claim. Then the inactive ingredients are all the other stuff. The active ingredient in desensitizing toothpaste would be 5% potassium nitrate, regardless of the brand. It's always 5% potassium nitrate. So the difference between Sensodyne and another brand, Colgate desensitizing toothpaste, might be just taste, or the Colgate might have something else added to it. They have something called arginine now. It's an amino acid, but arginine is really a great product for desensitizing teeth. Colgate used to have a special paste that we would polish with prior to scaling. That was very effective. They took it off the market because it wasn't selling enough. So Tom's of Maine, then, which is a Colgate subsidiary, has a toothpaste with arginine in it. So we all went out and bought Tom's of Maine, and we were polishing with that, and patients were quite happy. They like knowing that we're doing something to try and eliminate or alleviate some of their sensitivities. Some of it might be psychological, but we're trying to do something. All right, so you want to look for stuff with arginine. So Colgate has a new paste out that you polish on with the Profi cup, and then you give the tube to the patient. So they're purchasing the tube so that they can maintain that at home. But you want to look for what is the patient seeking, what do they need to make your recommendations. That's why Johnson & Johnson is going to provide you with all the information and the patient samples, so you're not pre-making your quote unquote goodie bags, which we don't call them goodie bags anymore because it's really demeaning what we're trying to give them, but we are customizing what you are recommending for the patient. Then you're looking for contraindications. So for some of this, are they allergic to fluoride? Are they allergic to something? Are they on some sort of a regime where they can't, for whatever reason, have any alcohol? You won't want them to be using Listerine with alcohol. They do make a non-alcohol based, but you always want to tell the patient what they're rinsing with. Sometimes it's a religious or a philosophical issue that they don't want anything with alcohol. Sometimes they're in a program. You just never know. So you inform the patient, I'd like you to rinse with this. This is Listerine. And if there's an issue with it, they will ask. Patients must be shown how to rinse. Why is this slide up there? Because you want to have a vigorous rinsing. Swish, swish, swish. You want to force that fluid in between the teeth and to get all the surfaces. Most patients will just kind of go swish, swish, spit right back into the cup. You want them to be swishing vigorously for 30 seconds because it takes that contact time. So we have how to rinse. And then take a small amount of fluid in the mouth, close your lips tightly because you don't want them spitting. You force that fluid through, right? You want them to get that liquid up around their lips, their cheeks, their tongue. You want to see them really balloon out their cheeks, then suck it in between, in, out, divide the mouth up into parts. Okay, I'm forcing the fluid in the front, forcing it to the right, and forcing it to the left. Do we really do this in real life? No, but we ask the patient to vigorously swish and follow the manufacturer's directions on the amount, length of time, and frequency. So chlorhexidine are two 30-second rinses. Swish for 30 seconds, spit it out, swish for another 30 seconds and spit it out if the patient's using it at home. Because as we're swishing, saliva is being incorporated into the swish and it's diluting it. But for our purposes in clinic, a 30-second mouth rinse with whatever we deem necessary for the patient. The non-alcohol mouth rinses do not work as effectively as bactericidal as the alcohol-containing rinses. But again, the best thing the patient can do is brush and floss. Now, has anybody tried oil pulling? This is one of those holistic things.
I've done it before with like olive oil.
Yeah, and how long were you swishing with it for?
I think I swished for probably like a minute.
Oh, is that all? Okay, because some of this can be quite a long time.
Yeah, it's
like
gross.
minutes, I guess.
Yeah. Well, and I made a comment to a student once going, I can't imagine swishing with this in my mouth. And she goes, well, you chew gum, don't you? And she was one of those, I'm calling her a tree hugger, right? But just very natural, didn't want any fluoride and everything else. But oil pulling, check the science behind that because it's getting to be more and more popular. With some sort of oil, you're swishing with it and swishing with it to help reduce the biofilm and reduce the bacteria. Coconut oil is one of the big things that oil pulling is being used with. I have not done sesame oil. I tried olive oil and I'm Italian. I mean, but unless I just can't swish with it, unless I got a loaf of crusty bread, now if that could be considered oil pulling, I'm good. So you need to know what to recommend for your patients. You want something that is tested. You want something that's proved safe. You want something that the patient can go and purchase on their own. Now, just because they have the ADA seal of approval does not mean that it's any safer or better than something else that hasn't been tested. All it means is that company has spent the time and money to have it tested. So the Food and Drug Administration gets involved, and they are the ones also to regulate any dental products. They're the ones that say you have to have an expiration date on everything, and that expiration date is 2 years. So if you've got a toothpaste that you found in your linen closet that's 2 years old, is it no good? It's probably just as good. We don't know. The FDA just came up with this 2 years. Evidently, it was arbitrary. So it doesn't mean that it's gone sour and it's not going to work. Do I use expired toothpaste? If I've got it, I use it. Yes, but you want to know what you're recommending for your patients, and you want to know what's being popularized out there as well. So the American Dental Association evaluates over-the-counter products, but the company has to get the ADA seal of approval, has to submit for that. So it's a voluntary program. So what we usually recommend to patients is, as long as it's got the ADA seal of approval, go for it. But that ADA seal of approval, for example, Crest, I'm just throwing that out there, might only be the ADA seal of approval for cavity protection or caries prevention, for nothing else. So you want to look at what they are claiming. I have even recommended products that don't have the ADA seal of approval, but they have science behind them. They just didn't want to get into the politics of getting that acceptance program. And one of the speakers that we have coming up on the 22nd of February is one of those scientists that has the science behind it, but didn't want to get into the politics. So if any of you can take that, it's going to be a fabulous CE. I'm going to send out another reminder. Billlanders, he's local, and it's wonderful. I'm one of his followers, so to speak. So know what the ADA seal of approval is. They have to reapply and continually re-up that seal of approval. But basically, you can't go wrong if you're telling the patient to get the ADA seal of approval. It means that they've gone through something. You want to also document on what you're recommending and why, so that you can follow up at their next appointment. Or if they call and say, my mouth is going through this or going through that, and the front desk, pulls their chart up, you're not going to remember everything. And they might be having a reaction to the tartar control formula, the pyrophosphate. That's been known to have some tissue sloughing of the buccal mucosa. Listerine essential oils can create tissue sloughing. So you want to write down what you're recommending so you can follow up with the patient. What did you instruct the patient to do? Swish for 30 seconds, twice a day. Okay, and then keep notes that way. So we're always educating our patient. You are going to be spending time at these oral hygiene aisles, looking to see what's out there, what is eye level, what's up, what's down, because there's where the eye level is where all the money is being spent. But they've got a lot of good products out there, and the patients are just overwhelmed with choices. So the more you know, the better. And that is it. Are there any questions?